Hello everybody, my name is Jörg Hausleiter and I'm welcoming you today to the EuroPCR e-course. Today we are discussing the treatment of tricuspid regurgitation with the PASCAL repair system, ready to make a difference. This is going to be a roundtable discussion on the just recently approved tricuspid valve repair system, the PASCAL repair system, which we will see in a few minutes in more detail. With me, I have two esteemed colleagues, Dr. Stephan from Bardeleben, who is the director of the Structural Heart Program at the University of Mainz, as well as Philipp Lurz, who is also the director of the Structural Heart Program in the Leipzig Heart Center. You see also here the agenda of today's meeting. We will discuss the PASCAL repair system for the tricuspid regurgitation. You will see several cases, one live in the box case and two other case presentations. And we will also discuss the current clinical evidence for the PASCAL tricuspid repair. And with that, I would like to ask Stephan to start with a presentation of the PASCAL repair system for the treatment of tricuspid regurgitation.
Thank you, Jörg. Dear Philip, I'll just make some introductory slides, 4 of them, for the PASCAL repair system for the treatment of tricuspid regurgitation, an indication that has just been CE marked recently in Europe. These are my disclosures. The PASCAL implant is unique in having a edge to spacer to edge capability to treat the leaflets on tricuspid regurgitation, mainly in functional but also in degenerative disease. You can see the central part being a spacer that actually approximates a gap between 2 different leaflets, both on the mitral as well as here on the tricuspid side. You see the broad outside contoured paddles, which help to minimize reflux from the valve. And a very unique and important feature of the PASCAL system is the independent leaflet capture capability, which was used actually in the first experiences in up to 90% of the implant attempts. The PASCAL delivery system has a direct maneuvering capability and it is not clocked. So we're able to independently steer the guide sheath, the steerable catheter, and the implant catheter throughout the procedure. And this makes it possible to gain height to the tricuspid valve from the inferior caval vein, but also to take advantage of the relatively slim design. It's only a 22 French guide sheath. And to the independent catheter steerability allows to reach actually almost all necessary implant positions throughout the tricuspid leaflet therapy. There are some unique features about the tricuspid valve that becomes more and more known in the experience since 2015. We have very dense chordae, so there's also a high variability of chordae in the quantity, density, and also in its location. And generally, the tricuspid valve is unique because it has very thin and fragile structures. And this corresponds to both the cords as well as the leaflets. They appear thinner, so they are harder to visualize, actually, on echocardiography. And we typically see 3 leaflets, but a variability with deep clefts and folds. On the right-hand side, you see that the large annulus mainly dilates over the anterior and the posterior leaflet position. And the tricuspid valve has one of the largest annulus within the body. Most of the TR that we will now see in the case presentations will be functional disease, which is present in about 90% of the cases. On this last slide, these unique features that you will also see in the upcoming case presentations are summarized. So one feature is that we can elongate the device, as you can see in the first image here on the left-hand side. which gives the whole device a very slim profile to advance in the sheath, but also to reposition. A very important feature that we will also see on the case presentations is the optimized and time-different independent grasping capability to optimize the device placement. Leaflet capture can be independently achieved, as you see here on the left-hand side, on both sides of the device, and you see an element that grasps into the leaflet and prevents a leaflet detachment from the PASCAL device. The whole design with only one frictional element is designed to be maximally atraumatic and reduces the stress of the leaflet. On the right side, you see the situation of the paddle, of the clasp, and also of the central spacer that is designed to bridge the coaptation gap and not to approximate maximally the tethered leaflet in tricuspid valve disease, which is caused by annular dilatation in functional tricuspid regurgitation. So this would be the introductory remarks on the PASCAL system, and I now give back to Jörg Hausleiter.
Thank you very much. It's now the pleasure for me to present you today the first commercial PASCAL tricuspid case which has been performed. These are my disclosures. I'm presenting you a patient which is 80 years old. She has no coronary artery disease. You see the interprocedural transesophageal echo. You see the tricuspid valve. Although the majority of patients have functional TR, this is a patient who has combined functional and degenerative disease, a very severe tricuspid regurgitation. You see in this 3D image here the septal leaflet on the right side, the anterior leaflet between 5 o'clock and 9 o'clock, and between 9 and 12 o'clock, the posterior leaflet. Again, in the 3D color flow, you see the severe TR originating in the central area of the tricuspid valve. This is now the transgastric view. Again, you can see the orientation of the septum to the right, the aorta at 5 o'clock, the anterior papillary muscle, which is the anatomic landmark between the anterior and the posterior leaflets, the central jet extending in the anterior septal line of coaptation. Now the treatment plan was to treat this tricuspid regurgitation with two devices, one in the connection between the septal and the anterior leaflet, and a second device between the septal and the posterior leaflet. You see the measured gap sizes, which were around 4 millimeters. This is already in the procedure. I'm advancing this 22 French guide sheath into the right atrium. You see by fluoroscopy just beneath the TE probe the guiding catheter. The guiding has been positioned, and now we're removing the introducer and the wire. We're always very careful that we're de-airing the system, and now the prepared PASCAL system is being introduced into the guide with a continuous flow. Again, we are aspirating the guide to be sure that there is no air in the guide, and then the system is being introduced to the tip of the guiding catheter. You see this on the right side. I'm pulling back the guide, so I'm exposing the PASCAL system in the right atrium, which is being seen by fluoroscopy and echo. And then the system has been closed. And by pulling and turning the knob on the steerable guide, we can flex down the system so that the PASCAL system is just before the tricuspid valve. It is very important that we are perpendicular to the tricuspid plane, and due to the several degrees of freedom which the PASCAL system has, you can always achieve this perpendicularity to the tricuspid plane. The system has been opened, and now we're checking the individual actuation of the clasp. You have seen the septal leaflet now in the shadow of the beam, you see the actuation of the anterior clasp. The 3D helps us in the first orientation while the system is still on the atrial side to get a good perpendicularity to the line of coaptation. You see here, this is being finally checked in the transgastric view. So we want to place the PASCAL system as centrally as possible in the anteroseptal line. Now you see that I moved over the PASCAL system to the anterior leaflet. We have a deep insertion of the anterior leaflet. And when we confirm this now in the mid-esophageal view, you see this on the right side, where the anterior leaflet is now nicely falling onto the device. I'm pulling it slightly back so that we have a good leaflet insertion, and we are sure that the leaflet is deeply inserted. The anterior clasp is coming down, as you have just seen in the last second. This video loop is being acquired so that we have the review option at a later point. Now we're doing this so-called Tarzan maneuver, that we're swinging over to the septal leaflet and trying to catch the septal leaflet again. You see that the septal clasp has been pulled down. Again, this is quiet. We are looking, before we go to close the system, that we have a good leaflet insertion, and then the system has been closed. You see the nice going in of the anterior leaflet into the device, confirming the leaflet insertion in the transgastric view, and then closing of the system. You see the leaflet insertion in the anterior leaflet. But there is quite some mobility of the septal leaflet. We are checking this in several views. You see that there is already a reduction of the color flow, but the septal leaflet appears to be in. But also, if you see in the next few images, there's still quite some mobility of the septal leaflet. So we were not happy that we had a very good grasp of the septal leaflet. So this is the reason why we're gonna try to do an optimization procedure, meaning that we're reopening the PASCAL system, swinging again over to the septal leaflet, opening the clasp, and when the leaflet is nicely in, we are reclosing the clasp so that we have a maximum of the septal leaflet in the device. You can appreciate here that there is a deep leaflet insertion. I'm closing the device in a few seconds. And then I think you can appreciate a significantly better leaflet insertion in the PASCAL system. Again, here you can see how deep the septal leaflet is running into the PASCAL. Now we're very close to the hinge point of the septal leaflet, trying to confirm the leaflet insertion here again, and we see that the anteroseptal line of coaptation has a significant reduction of the TR. There is still some jets remaining in the central part, so between the anterior and the posterior leaflets, and in the posterior region. We're checking the gradients. The mean gradient was only 1 millimeter of mercury. We're confirming the leaflet insertion now and the positioning in the transgastric view. You can nicely appreciate the septal leaflet as well as the anterior leaflet running nicely into the system. Now the PASCAL system is being detached. We're pulling on the sutures which are actuating the clasps. The lock is being removed, and by turning this blue knob, the PASCAL is being disconnected from the catheter system. Here you see by fluoroscopy the stable positioning of the PASCAL. in the anteroseptal line of coarctation. As planned, we prepared a second device, which is now being introduced into the guiding catheter. Residual air is being aspirated. Now I'm advancing the system to the tip of the guiding catheter, and now we have to come out very, very carefully with the system so that we are not entering this interatrial septum, because this is just here in the direction where the system would come out. You see the exposure of the PASCAL system in its elongated version. When the system is fully exposed, the system is being closed, as you can see on the right side. And now we have the space and the room to fully expose the steerable catheter, so that we can now bend down the system just in front of the tricuspid valve. Again, you see on the right side the perpendicular orientation of the catheter system to the tricuspid valve. You can appreciate here in some of the views the first PASCAL in the anteroseptal line of coarctation, which is also very nicely seen in the fluoroscopic view. Now we have to repeat the same procedures when we're perpendicular to the system. The PASCAL is being opened and the clasp check is being performed so that we know which clasp is being functioning. So this is the septal clasp working independently, and the second has been also tested. Now we need to orientate the second PASCAL system in a V configuration so that both septal arms are connecting to each other, so that we are perpendicular to the line of coarctation between the posterior and the septal leaflets. This is being, again, confirmed in the transgastric view. We need a little bit of clockwise rotation to be perpendicular, as you will see in a second. And now we are confirming this also. We're orientating our fluoroscopy system so that we are perpendicular to this system, so that we always have a fluoroscopic feedback if our system turns while we move now into the right ventricle. We just want to be as close as possible just beneath the first PASCAL system, as you see here. This is being performed by fluoroscopy as well as echocardiographic control. You see in this transgastric view that we're just beneath the leaflets of the tricuspid valve in this posterior location. When we're in this location, the system has been opened again very, very slowly. Now you see also by fluoroscopy that we're just beneath the leaflets. A good echocardiographic window in this mid-esophageal view is being looked for. You see that now the posterior leaflet is falling nicely on the posterior arm. The clasp has been pulled down so that we have a nice leaflet insertion of this posterior leaflet in the PASCAL system. The septal leaflet is already bouncing on the septal arm. We will try now to optimize this leaflet insertion then also for the septal side. With a small tarsal maneuver, there is not a lot of movement necessary. Now the clasp for the septal leaflet has been pulled down so that we have a nice tissue insertion of both leaflets, which is being confirmed by different views. Here you see the transgastric view. You see how the posterior leaflet is running into the device, and you see it also coming up from the posterior side. We're confirming this also in the mid-esophageal view. Again, you see that the septal arm is close to the hinge point of the septal leaflet. So have also here a very good tissue insertion. And now when we are sure that we have a good result in terms of leaflet insertion, the device is being closed. And again, the video loop has been acquired. Now we see the the result in terms of color Doppler flow. There's a significant TR reduction with some jets remaining between the two devices, but overall a very significant TR reduction. The gradient was measured to be 2 millimeters of mercury. You see in the 3D view while the second system is still connected to the catheter system, a nice V configuration with the small tiny jets mainly between the two devices originating. You see that we're generated by this more or less a triple orifice, one orifice in the posteroceptal connection, one in the AP line of coaptation, and in the anteroceptal line of coaptation. The Doppler color flow also here demonstrates that there are only minor jets remaining, so we were safe to now disconnect the second PASCAL system. Again, we have a very stable positioning by fluoroscopy, but also by echocardiography. You see these two devices very close to each other in the central part of this tricuspid valve. And up with the detached systems, also a very good and durable result, which has not been influenced by the release, just very tiny small jets remaining mainly between the two devices and one jet, small jet from the posteroceptal line of coaptation. So with this, I think we could have demonstrated that with the insertion of two PASCAL systems, we were able to reduce the TR from a grade 4, as we measured it to be before the procedure, to a grade 1 at the end of the procedure. The patient was already discharged, feeling significantly better after this procedure. Thank you very much for your attention.
Congratulations, great case, excellent result, and this is the very first commercial case. Absolute fantastic. You implanted two devices. Could you comment on that a little bit? Is that a very common approach for you when you treat tricuspid regurgitation with the PASCAL device?
Well, I think we have to respect always, of course, the anatomy, the size of the anterior leaflet and the size of the posterior leaflet. In this case, we had two leaflets which were approximately of the same size. And I think in such a case, if you have then the pulling forces from the anterior leaflet as well as from the posterior leaflet to the septal leaflet, which works as an anchor for the GR treatment, then we get overall a very good long-term durable result with this double device technique. Of course, there are some pathologies where one leaflet is significantly larger than the other. Then, of course, you're only treating the larger leaflet, or sometimes even it is sufficient just to place one device in the center of the valve and abolishing the TR jet already with one device.
Yeah, congratulations. I think it has been a very nice demonstration of the capabilities of leaflet therapy in tricuspid valve disease. Could you comment a little bit on the imaging requirements? We've seen that we had nice images, especially interestingly enough, after the first placement, the images on the second clip even seemed more favorable than on the first. Can you comment a little bit? How are your positions? Are you going deep transesophageal? You showed the transgastric views. What is your perspective here, Jörg?
Well, thank you very much for your comments on the image quality. Of course, I was not on the handling of the probe, But imaging for the tricuspid intervention is probably the most crucial aspect for all intervention and the most difficult. Steering the catheter is probably significantly simpler than achieving good image quality. As you have seen, we are working mainly with TEE imaging, but also I want to highlight the need for fluoroscopy. Fluoroscopy is, for me, I think, a very crucial aspect for the treatment of valves with the PASCAL device, because you always get a very nice and a very quick feedback of your rotation of the device. And that helps you to cut down in your time, and you're much more precise in the positioning of the device in the valves. In terms of the TEE imaging, as you have seen, we're mainly using the deep esophageal and the transgastric views on the tricuspid valve. The 3D is of some additional help, but is significantly less important than on the mitral side. The cross-plane imaging always helps you to orientate yourself where you are in the tricuspid valve. So we have always these standard views of cross-plane imaging to really get a good understanding where the device is in respect to the anterior and especially the posterior leaflets. So thank you very much. It's now my pleasure to introduce Philipp Lurz from the Heart Center from Leipzig, and he's going to summarizing the clinical evidence which we have achieved for the PASCAL tricuspid repair system. Philipp.
Thank you very much, Jörg. Dear Stephan, dear colleagues, it is my pleasure to give a summary of the current evidence we have so far for the PASCAL system in treating TR. The body of evidence so far comprises of two parts. The first part is a series of compassionate use cases. These were performed at 4 centers in Germany, 1 center in Canada, and 1 in the US. In total, 28 patients were treated on compassionate use grounds. The baseline characteristics, as summarized here, are the ones we typically see in a cohort of patients with severe tricuspid regurgitation, elderly patients, mean age 79%. The majority were women that were highly symptomatic, a lot of comorbidities, and about 1/3 of patients had previous valve interventions on the left side. Here you can see the summary of the procedural results. Procedure success in this very early experience was 86%, and this certainly includes a learning curve. Now, importantly, operators in this series, they made advantage of the unique feature of the PASCAL device, the independent grasping of leaflets, which appears to be particularly important when treating the tricuspid valve. The safety in that series was quite good, very few complications. However, there were 2 patients who died within 30 days. That's a reflection of the frailty and high risk of this population. In total, there was good reduction in tricuspid regurgitation after the procedure, and also at 1 month, more than 80% had moderate or less tricuspid regurgitation, and that also resulted in a remodeling of the right ventricle as seen by a reduced size of the RV. Also, clinical benefits were documented, significant reduction in symptoms with reduced NYHA class and an increase in 6-minute walking test in these patients. Now, the second body of evidence we have so far comes from the results of the CLASP TR early feasibility study. So this is a study with a predefined protocol, prospective, multi-center, single arm. All patients were discussed within a heart team to assess morphological but also clinical suitability for such a treatment. This was a US study only with 9 centers, very similar baseline characteristics to what I've presented before in the compassionate use series. Also here, the implantation success rate was 85%. In 4 patients, the procedure could not be performed, but in those where it eventually was attempted, successful implant rate was up to 100%. Very few complications, 2 patients with severe bleeding, and then also a few cases with a single leaflet device attachment. That can happen, but this is not very common, and in that case, 3%. Here you can see the summary of the reduction in tricuspid regurgitation. The percentage of patients with moderate or less TR in this series was a little bit lower than what I've presented previously. However, it is important to realize that baseline TR was very high. There were more than half of patients with baseline torrential tricuspid regurgitation. And when you reduce TR by 2 grades in these patients, they end up with severe but still have 2 grades of TR reduction. That happened in 70%, and 85% had at least 1 grade TR reduction. And this is only the beginning, and it continues with the Class 2 TR trial. This is a randomized trial enrolling more than 800 patients, where this intervention will be compared to optimal medical therapy only, and the results of this trial will put the whole field on very solid scientific grounds. Thank you very much.
Great, Philipp. This was a nice summary of the clinical evidence, and it's now my privilege to continue with you so that you will give us a nice presentation of a case which you treated in Leipzig.
So my pleasure to share with you our first commercial PASCAL TR case. That was a 77-year-old woman with long-standing persistent atrial fibrillation. She was diagnosed with HFpEF, preserved left ventricular ejection fraction, with mild pulmonary hypertension. She had some episodes of symptomatic bradycardia, and for this, very recently, pacemaker implantation was performed. So there is a lead across the tricuspid valve, and she also has diabetes mellitus. Her Euroscore was calculated with 10.8, so not extremely high, but she had objectively demonstrated frailty with reduced gait speed and grip strength, and therefore the decision within the heart team was that transcatheter approach is most suitable. Here you can see patient's anatomy. In the very center, you see a broad TR jet extending almost from one commissure to the other. So this is that was quantified as torrential, so grade 5 tricuspid regurgitation. The right atrium, as you can see here, is very enlarged. There is extensive coaptation defect and an appearance which we refer to as pseudoprolapse of the septal leaflet, and then lengthening of the anterior leaflet, something we quite commonly see in functional TR, but in a condition we refer to as AFib TR or atrial functional tricuspid regurgitation. On the very right, you see a transgastric view, and it is important to highlight that there is a lead across the tricuspid valve, but that sits very much into the anteroseptal commissure and does not significantly contribute to the tricuspid regurgitation. So in this case, is more or less an innocent bystander. The strategy in that case was a 2-device strategy, considering that the extent of the TR and the coaptation defect, which extends from anteroseptal towards central and posteroseptal, and because of the huge coaptation defect, staged grasping was the preferred mode of choice. So first device was intended to go in there between anterior and septal, and then the second device more centrally between septal leaflet and then that leaflet, which I would refer to as an intermediate or mural leaflet. Here you can see the implantation of the first PASCAL device, transgastric view, certifying that the device is nicely orientated, perpendicular to the line of coaptation in a 2 to 8 o'clock fashion. Here you can see the device with the anterior leaflet already in, and also the septal leaflet before closing of the device, and that's what it looked like after closing. So there's nice tension on the anterior and septal leaflet, implying that both leaflets are nicely in. After release, we saw this, so there is still TR. It came down by 1 or 2 grades after the first implant, but not yet satisfying, and therefore we proceeded with the second implant, and this is summarized here. Again, a transgastric view. We control for the clocking of the device. It is now positioned to grasp the central leaflet and the septal leaflet. For this implant, you can nicely appreciate that we grasped first the anterior leaflet and then we swung over to the septal leaflet, so stage grasping, which certainly is necessary in these larger coaptation defects. That's what it looked like after the septal leaflet was in the entire length, touching the apex of the device. The clasp was put down, and this is then the final result on the very right. That was quantified as a TR grade of mild to moderate, so 1+, on the left before. So in total, we were able to reduce the TR by 4 grades, and we were happy with the result. Patient was discharged next day and was feeling already better. Thank you.
Philipp, this was a very nice case presentation.
Absolutely, congratulations. I think the image quality was superb. It was very good to see this kind of result, and also the control that is possible with the device.
I have a question for you. Did you expect that you will be able to get such a good result with the PASCAL system from your previous experience?
We were confident that with 2 implants, we would be able to reduce it by significantly, certainly by 1 grade. I expected 2 or 3 grades, but I did not expect it to go down to only mild, considering that we started off with torrential. So we were very pleased with that result, obviously. When I think it's very important to set the expectations before, and when we treat patients with torrential TR, then we try to reduce it to moderate. We do have some evidence that when you reduce it by 2 or 3 grades, even if they end up with moderate TR, that they benefit from a clinical perspective, very much so.
If you look back to in your experience, what do you think is the most important aspect of the new PASCAL system compared to other systems? What helps you most for treating those patients?
I mean, if you compare the treatment of TR to what we've done for many years on the left side for the mitral valve, the 2 important differences. One, the leaflets are thinner, they're more fragile, and secondly, the coaptation defects are bigger. And this device has 2 features which are very handy for these 2 differences as compared to mitral. The way it grasps the leaflets is quite atraumatic. So you can do multiple attempts without damaging the leaflets. And then secondly, the staged grasping allows you to bridge larger gaps. And this is why this device is so important for treating tricuspid regurgitation.
A third point is, if I may add it, is the contour of the pedals and the size of the pedals. This may also take away a lot of the stress. What I found very interesting in your example, Philipp, was that the anterior, the commissural regurgitation got better as you treated the valve posterior to the first PASCAL. Could you comment on this? This was very interesting to see that. How do you explain it?
Nicely spotted. Right. I think what we do with that procedure, obviously we try to implant the device and treat the lesion where it is. But in addition to that, by connecting either the anterior or posterior leaflet to the septal leaflet, we pull over the RB-free wall towards the septum, and in addition to a leaflet therapy, we should get an indirect annuloplasty and a reduction of the right ventricular annulus. And I think this explains why sometimes after the second device you get reduction of TR away from the location where you implant the second device.
I think this was a very, very good summary of what we have just seen from this beautiful case from Leipzig. And with this, I think we will continue now with the next case presentation, which is coming now from Mainz. Stephan, you want to present your patient?
If I may, yes. Jörg, dear Philipp. So I would now go back actually in time and go to 2019 and show you the first European Union compassionate use case on tricuspid regurgitation from the Mainz Heart Valve Center. So this is also a typical patient. It's a male, 75 years old, with dyspnea, not able to walk actually. Interestingly, if you see the BNP value is not very elevated, with just below 200 picograms per milliliter. But the patient had pronounced peripheral leg edema, repeat episodes of heart failure. It had received a mitral clip 3 months earlier, had coronary artery disease without relevant stenosis, AFib, which is typical for 90% of the patients, preserved diuresis and renal function, good LV function, and a TR grade 4/5 with a good result after mitral clip. And we attempted a transcatheter tricuspid valve repair in this patient. You see the initial images, and it's very interesting to see what you see in thoracic echocardiography. And if you look into TOE at the day of the procedure, you can appreciate that the same regurgitation can appear quite massive actually on TOE, as you see here, with a typical gap in the leaflets. But also here, this is a massive dilatation of the right atrium with a preserved right ventricular function, and these patients do have a benefit. We see on the left-hand side a three-dimensional reconstruction. We all mentioned that actually 2D and also biplane imaging is more important, but it gives you a very good appreciation of the distribution of the massive regurgitation in this case. And now we see actually, and you see in Mainz, we like to demonstrate the 3D capabilities, also the preparation. And here you see the two clasps and also the wire nicely in preparing and orientating before the procedure. And for the first time in these case presentations, you also see that we can control this nicely in fluoroscopy. And you see the two different clasps going down to the pedals and actually tracing down the leaflets into the device for a very good result. So this is a typical image that we've seen in both presentations by Jörg and by Philipp. And you see that we use a 60-degree to 80-degree view, in this case over the left atrium into the tricuspid valve. We try to get perpendicular to the device. And here we have a 4-chamber view where you can control separately the septal clasp and the anterior clasp in this patient. Transgastric views have been shown nicely, and we also use this to actually close the device, which you can see here. And you can nicely see how the leaflet edges run into the PASCAL device that you can control here, and that we get an approximation of the gap that had been in the range of 4 to 7 millimeters in this case. So this is the first PASCAL. To suit the Munich technique, and we're not touching here the mitral clip, but we're implanting here the first PASCAL. And here on the right-hand side, upper is anterior, lower is posterior. We're doing actually the Clover technique that you have seen in all 3 case demonstrations in this seminar. So the first device and the second device, where you can nicely see how the clasps go down here and how the system is then later controlled. The pedals are being closed at the end. And this is also controlled in echocardiography. Here you see the same images in echocardiography. You see the devices being closed. You see the approximation of the femoral wall and annulus nicely in this patient. This is the result after 2 PASCAL systems, also very nice. So we would call this a 1 to 2 plus TR. But what is interesting is that we can provide the 1 year, even the 1 year follow-up in this patient, as this was a compassionate use last year. And the patient just came back this week in order to get his follow-up 1 year result. And you can nicely see that this is a TR 0 to 1 after 1 year. You see a remodeling of the formerly gigantic right atrium. The BNP values totally normalized, and you see still a very good function on the left-hand side and right-hand side. And we have no regurgitations on the EV valves with a mitral clip on the mitral side, and the first double PASCAL here on the tricuspid with a 1 year result. I think this is a very favorable situation, and my take-home messages would be, like with Philipp and Jörg, that independent grasping enables a stage clasping or grasping of the leaflets to optimize the results, and that intraprocedural imaging, as you have seen, is key. The transgastric and deep transesophageal views can help you to overcome imaging obstacles, and this would be my remarks for this case presentation.
Wonderful, Stephan. I have a question for both of you, because you have nicely shown how you're closing the valve. We have in all 3 cases placed 2 devices. Each device has a width of 1 centimeter, so they're pretty big. And we could always speculate if we will run into some significant tricuspid stenosis or tricuspid gradients. Would the both of you would like to comment on this phenomenon? Is it a real phenomenon? Yes or no, Philipp?
In short, one should not be misled by the mere size of the device. First of all, the tricuspid valve, the annulus is large, and normally you can easily accommodate 2 devices, especially when it's been dilated, as always in TR. And then secondly, this is not a screw. This is more like a spring. It can open and it can close slightly throughout the cardiac cycle, and it does not restrict leaflet mobility to. Or it restricts leaflet mobility to a lesser degree than probably what we are used to, and I think that explains why we hardly ever see high gradients.
I totally agree. I think we have a dynamic device. This is a dynamic shell-like structure. So the 2 pedals, in my opinion, open and close. And I think either in your case, Jörg, or in your case, Philipp, I've seen a dynamic opening and closing. I think it was your case where you see this bouncing also of the clasps. And the same can be seen a little less pronounced with the pedals. So the whole system is slightly elastic and dynamic. And this is nitinol. It is not stainless steel. It is not so much pressure on the leaflets, but it's cooptation to the pedal and cooptation of the leaflets at the edges of the central spacer. And I think this shape is a very important part of the success that we see with this device in TR reduction. And I think all 3 cases that we demonstrated showed the same direction here. And we had in 3 different centers very similar approaches with tiny changes, but I think it shows that this really works.
Let me just go back to the tricuspid stenosis question. What kind of gradient do you see regularly, and what do you think is going to be acceptable for tricuspid intervention? Because I think this is always a question which we need to discuss.
I think stenosis starts at a lower gradient than what we see in the mitral. So we typically stop already if we can decide on stopping at a gradient of 3. These cases that you've seen in your case, also in this case, had gradients of 1.5 to 2 after 2 devices. So they're ultra low gradients, I think, and we should aim at those low gradients. We shouldn't close the valve. But even your tricuspid opening still showed a quite laminar flow, inflow, and not a stenotic inflow. You had no vena contracta in the inflow situation. And I think the gradients are remarkably low compared to the size of the pedals. We have 10 millimeter width, but it's amazing. Also, after 1 year, this patient has no stenosis whatsoever. She is still at 2, or this patient, it's male patient, is still at 2 millimeters mercury. So no increase over 1 year.
Wonderful. Just the final question for both of you. Are there any comments you want to make on the system and what you think is the most important aspect for you, both of you? Philipp, you want to start? Besides what we have already discussed?
Flexibility, reliable steering, and independent grasping. I mean, we've seen it in all cases. It is essential to treat larger gaps. And the other feature, for the operator to feel confident to go for multiple grasping attempts without having to fear that one damages the leaflets.
Stephan?
Yeah, I would say little impact and damage to the leaflets. That's an important point. And I would also highlight that about 90% of the clasping attempts have been done with staged or independent clasping. And I think this is a very important feature, as you called it, the Tarzan technique or the swing over technique, whatever you like. But I think this is important. And we shouldn't underestimate the role of the spacer in combination with the pedals. So the shape design plays also an important role.
Wonderful. I think this was a very great session, a good summary of what we have seen in these three cases. So I think this new device, which is now available, at least in Europe, will help us to treat our patients more effectively. And I'm pretty confident that we're going to see that in the future, this device will have a great impact on our patients. With that, I would like to thank you both for your contributions. I think we have seen great cases, and I want to see more of those cases in the near future. Thank you very much for your attention. Bye-bye.
Bye.
Thank you. Bye-bye.